I wanted to say good morning because this session was still the morning session, but it's now afternoon. So what we are starting from is, I want to start from the end. By the end of the day today, we will have received the MTR analytical review findings. We would have received the MTR main report findings, and we will have received the MTR of the Health Basket Fund. That is my instructions for today, and I plan to fulfill them. So I need your help with that. And we will do like this. We'll have presentations for the analytical findings, then a brief discussion, then we'll have the MTR main review. We'll also have some discussions at the end, and then the basket. So please indulge. We will do that. We'll decide when we can have lunch. When I grew up, we were having 1 meal a day. So usually it was around 5, then you go and sleep. So whenever time we have for the meal, we will have. We didn't come here to eat, we came here to work. So, and it helps with the NCDs, not eating so much. So, so let's start with, I'll start by calling up the analytical review team, Professor Simba and Professor Sia Msuya, who will carry us through the MTR analytical review findings. We'll give them half an hour minus 5, so 25 minutes for presentation, and then I'll allow discussion after that. Please, Sia, you are starting, eh? Okay.
Yeah. Good afternoon. PS and the high table, other delegates, and invited guests. I am really honored to stand in front of you and present some results of analytical report. Our leader of the analytical team was Professor Tiz Boema, who couldn't be here, but on behalf of the team, we will carry forward. As it has been introduced, the background or the purpose of this whole work was to inform the overall performance of HSSP4, and parallel with it, we also assessed the progress on 1 Plan 2. The approach has been presented with Dr. Catherine, where we analyze and synthesize the available data, and the team leader in all this work was the Ministry of Health, Community Development, Gender, Elderly and Children. We had a team of international and local consultants, and for analytical part, we had several data sources. Key among these were health surveys, demographic health survey, malaria and HIV indicator survey, STEP survey, national TB and HIV impact survey. We used the HMS database and program databases as well in the analysis of this work. We had some facility assessment data, especially the SARA survey, as well as financial, national health accounts, and infrastructure. As you know, there are 59 indicators on health system in the HSSP4, and we had 99 indicators on 1 Plan 2. The IT team, the high table is asking if you can enlarge the font. I will continue while they're there. So there are 59 indicators in HSSP4, and we had about 99 indicators in one plan 2, and about 20 indicators which overlapped. What we can say in a summary is that we have utilized DHIS2 data from 2015 to 2018, and most of the coverage indicators were good, and we used most of them. And for national level, and for national coverage data, especially level and trends, we have used also DHS and other survey data. We have challenges, especially in terms of target population, and I think that will be addressed later. Most of the analysis we have done is up to regional level, and there are no any statistics which was done for council level. And I think I'll start with the key findings. It has been presented before that we have made progress in under 5 mortality. Mortality or under 5 mortality. We have heard from several speakers we are not doing well on neonatal mortality, and we didn't see significant trends, and the level at 26 per, and the level were 26 in 2010 to 25 per 1,000 live births in 2015-16. But key among this, which all of you know, is that increasingly newborn deaths are now contributing to approximately 37% of under 5 mortality. What has been seen in the analysis is that the urban advantage has been lost in terms of under 5 mortality, and there isn't much difference on under 5 mortality levels between rural and urban areas. When we look at causes of deaths, and this was data from DHIS2, these are causes of death in the hospitals in 2018. What we can see most is still infectious diseases and parasitic diseases are the leading cause of death, among approximately 41%. However, and then the second one, you can see perinatal condition being the second cause of deaths from DHIS data. Circulatory, digestive system, and respiratory system are other causes, but what is important is that in the reporting of DHIS2, still ISD-10 use is still limited. This was the study done by NIMRI, which looked at pattern of causes of hospital deaths in Tanzania between 2006 to 2015 in 39 hospitals. And the key finding here, which you can see, is that when you look at malaria, when you look at HIV and tuberculosis, you can see there is decline as a cause of hospital deaths in this study. You look again, your neonatal disorders are contributing the death, shock, and then of course you have maternal and child complications. Let's go back to now fertility. These are the indicators. Now we are addressing the indicators which were in HSSP4. When you look at fertility, the total fertility rate is declining in Tanzania. And looking at Tanzanian Malaria Indicator Survey of 2017, we have reached 4.9, and we have achieved the target of reaching TFR of below 5%. Of course, urban-rural differences still persist. When we look at contraceptive use, when you look at modern contraceptive use, it is increasing at the rate of 1% annually. We are at 32%. We are increasing, but far away from our 2020 target of 45%. But of a note which I want you people to take home is that when you look at demand for family planning satisfied is only at 53%, so we are not doing well. And unmet need for family planning is still high. What you can get from DHIS data of 2017-18 is that when we are analyzing data, we found there was increase of long-term methods, especially implants. And it has taken over as the leading method of contraceptives from DHIS2 data. When we come to maternal mortality, actually, when we are going through the analysis, we do not have new population-based data. So the data which has been retaliated of 556 maternal deaths per 100,000 live births is the figure which stands. However, we had the DHIS and other facility-based reporting system showing about, they recorded about 1,700 maternal deaths, which is a mismatch when you look at the expected number of deaths when you calculated from maternal mortality ratio. So this was the new method of capturing data. We can't say much about it, but because we are basing on looking at trends which we get from demographic and health survey data. More or less, we miss local studies which assess mortality. Most of the studies which have been done on RMCH is on coverage use. We have limited number of studies which have looked at maternal mortality per se and different methodologies of addressing maternal mortality. What we are saying is that with the increasing rates of delivery, which we'll see, the coverage, coverage of institutional delivery, increasingly the data which we will get from institutional maternal mortality ratio will become a good approximation of where we are going with maternal mortality, but not at the current. When we look at coverage or use, the use have increased from along the continuum of care. When we look at, when we look at antenatal care, looking at 4 visits, as 60% from 37%. When you look at regions, you have 2 regions which have, these things are going differently. This and that. Sorry, there was a mismatch between that one and that one. Okay. So looking at ANC 4 more times, what we are looking at, there are some regions which are well performing and they're above the 80% target coverage. And there are some regions which needs to pull up. But what we are saying, when you look at antenatal care for the first visit, most of our women are still not coming at the first trimester. Looking at quality of care measures, we have some improvement as well. When you look at testing for syphilis, testing for hemoglobin, it has improved from 32 in 2015 to around 66 in 2018. When we look at institutional delivery, or people talk about SBA, they match. And what we are seeing is that there was rapid increase in birth at facilities. And looking at Tanzanian Demographic Health Survey, the coverage was nearly 63% in 2015 and 2016, which communicated very well with the DAH data, which showed 65% coverage of institutional delivery at 2015. And now it has increased to 77%. This is what I was saying. Women do come to the health facility for the services. And a good thing is that all the regions are above 50%. C-section rate has also increased to around 8%. And we saw a regional variation whereby in Njombe and Dar es Salaam have C-section rates of 25% and 17%, while Simiyu and Katavi has 2%. When looking at postnatal care as well, it has increased both for women and newborns, And nearly 66% of women and newborns do receive postnatal care within the first 48 hours. Looking at also the newborn, indicators of newborn, looking at early initiation of breastfeeding. When you look at the DHIS data, the last time it was 51%, but what we got from DHIS, which is facility-based data, it has gone up to 76%. So we are doing well on coverage measures. Looking at immunization, I think we all know that we are doing very well. 9 out of 10 children in Tanzania are immunized. We have high coverage of all the vaccines. But to take a note is some regions which you have some regions which are lagging behind. And for example, Tabora, you have largest number of infants who have not received Penta 3, and Penta 3 is the marker of how the regions and the whole system is doing in terms of quality of immunization. So followed by Simiu there, Shinyanga, Dodoma, Geita, and Mara. They have about 10,000 infants who are not covered by Penta 3. When we look at quality of care during delivery, stillbirths in health facilities, we see a slightly declining trend of stillbirths from 16 to 12 per 1,000 health facility live births. You have a very big marked regional variations in stillbirth rates. Looking at these two regions, Kilimanjaro and Kagera, we are talking at stillbirth of 6 per 1,000 hospital deliveries, while looking at these other two as examples, Dar es Salaam and Lindi, you have a stillbirth rate of around 18 per 1,000 live births. When we look at intrapartum stillbirths, fresh stillbirths, it's declined from 6.4 to 5 per 1,000, but we are not yet there. Child nutrition, it has been said, and the PS said it. We use the DHS data because we do not have any new data, and we all know stunting is at 34%, and your way we have to speed up, or we have to do a lot to reach the 2025 goal of 40% reduction, and underweight is at 14% by 2018. Dar es Salaam has the lowest stunting, about 15%, but the basket producing regions are still struggling with stunting, which are over 50%. We are talking about Rukwa, Njombe, Ruvuma. Stunting rates are much higher. Let's go to adolescents. What has been said is also has been observed in the analysis. The birth rate, adolescent birth rate is still very high, with 21% of 15 to 19 years old who have started childbearing. This is from THMIS of 2017, matching what has been said with TDHS, which showed it was around 27%. So we are not doing well when it comes to adolescent birth rate. When you look at adolescents who, along the continuum of care, use of health services, once they are pregnant, actually it doesn't differ much with adult women. So their access or use of health facility during antenatal delivery and postnatal is similar to adult women. But we are missing them there when they have early pregnancies and early childbearing. Then we try to summarize the progress, especially coverage progress, by using 11 indicators. It's more like the used in countdown report. And these indicators, for example, started from ANC 4 more times, ANC less than 4, when they attended ANC less than 12 weeks, IPT 2, health facility delivery, fresh stillbirth. So we have up to immunization. So it is a composite measure of 11 indicators trying to look at what is the progress of our maternal, newborn, and child health index in terms of coverage. The key issue, when you look at the national level, maybe I should draw your attention. When you see a dot, this was the coverage level of those composite of 11 indicators in 2015, and the bar graph shows you the coverage rate of 2018. So what you really will want to see is the bar much higher than where the point estimate was in 2015. And nationwide, in Tanzania mainland, we have progress in the maternal, newborn, and child health index based on the 11 indicators. But you have regions which have done so well. You have very big increase in coverage indicators, and others which have an average improvement. But overall, the coverage throughout the country, when you pull the 11 indicators, is improving. And then the analysis compared the BRN region, big results now region, and other regions in terms of composite measures of these 11 indicators. And you can see there was rapid increase in the MNSH index for BRN, and the gap is reducing between BRN and non-BRN regions. So it means what the input in BRN has paid off in terms of coverage of services. And then analysis looked at another way. They said, let's take and look at a health system score, whereby it was combined, coverage of health or availability of health facilities in a region and health worker density per region. And then it was, we did correlation analysis with the coverage or the MNSH index using the 11 indicators. And you can see the line, the linear line there, the regression line which was fitted. And as you see, as what is trying to tell us, the graph is trying to tell us is that when these ones improves, your health facility coverage and health worker, so is your MNSH score index increases. But you have outliers which we cannot explain, and I think we can have several PhD studies here. Look at Kagera and look at Kigoma. When you look at their composite measure of health system coverage and health care per density, it is way low, but they are performing compared to other regions. Take here Arusha as an outlier, which has higher coverage of health facility and healthcare workers, but is underperforming than the sister regions. So these are the findings from the data. We need explanation behind the numbers. And this is what it's trying to show us. And this is saying the same, but divided now according to lowest coverage of health facility and health workers density, and the score index when we combined the coverage of 11 indicators. And as you can see clearly, you have your outliers here. High coverage of facilities, healthcare workers density, but underperforming below the national level. Look at these guys here. Low coverage, but they're performing as much as well as this other region. When you compare Tanzania and other East African countries, when you compare Tanzania and other East African countries, of the 11 indicators, actually Tanzania is in the middle, whereby our neighbors are performing much well compared to us. Looking at Kenya and Uganda, we are along this graph here. Yeah, thank you. Professor Simba will come and continue with others.
Thank you, Professor Sia. Let me take you through now on the malaria side now. We go from the reproductive, maternal and child health care, and we go now to disease conditions, and we finish with the health systems. If you look at malaria, wow. There we are. Oh. Next. Oh, sorry, I'm faster than the electronics. So if we look at malaria performance, we'll be able to see that we have made some improvement, and in actual fact, we have achieved certain indicators, and we have improved in other sets of indicators, although we haven't reached the target. If I can point here on malaria cases that have been confirmed through laboratory, and you look again at this indicator that shows mother who received IPT2, these two indicators, we have achieved the target. But if you look at the first one, prevalence of malaria for those aged under 5, and the third indicator here, children with febrile illness who received diagnostic test for malaria, we have managed to make some progress. If you look here, there is some progress. And here, there is some progress. But then the target is quite far away. We are yet to reach it, and in fact, we may not reach it by 2020. And looking at the last indicator here, and this is ITN use among pregnant women and children, you can see actually the coverage has declined from the baseline. The use of ITN, we further elaborate here. You will see that it came up increasing, and this is among pregnant women. And from this year, 2012, it went down, and it has remained there. And the same picture you see for children under 5. HIV, we have been doing quite well in terms of control of HIV/AIDS, and to date we still have about 1.5 million people who are still living with HIV/AIDS. We have done quite well with PMTCT, and you can see the figures here that we are almost 99%, meaning that almost all women who are eligible for PMTCT get the services. And we also have decreased HIV prevalence among 15 to 24. And actually this indicator measures incidence because we are looking at the young age. So we can say transmission is decreasing from 1.2 to 0.6 for males, and from 2.7 to 2.4 for females. And we have reached the target that we have set for ourselves. With regard to ART coverage, we have made some improvement from 65 for adults, 25 for children. We went up to 75 for adults and 47 for children. But then if you compare with the target, 95 and 80% target, we are yet to achieve the target. We look now at the HIV treatment cascade. And what we see there is 75% of those who are living with HIV/AIDS are currently on care, and 98% are currently on treatment, and the retention rate is 84%, and suppression rate to achieve the 90-90 target. With tuberculosis, we have increased the notification rate over time, and you can see it here. And we also have attained quite high success rate over time. There was a little kink there. And we have increased the detection rate for those who have drug resistance to up to 450, and all are under treatment. The last graph shows the slight decrease in the percent of patients with leprosy cases that are under care. Outbreaks, we have had the, we have had joint external evaluation that was done in 2016 and 2018. If you look at these two evaluations, you will see that we actually have made achievement in 2018, whereby in all areas that were studied, they scored quite high. However, what was noted is that the target actually that we are putting here is score number 4. The highest score is 5, but our target was 4. So the achievement we had here was tagged against the score of 4 and not 5. And if you look at IDSR reporting rate, we have also quite high reporting rate in terms of timeliness and completeness. NCDs, we have quite some little data, I would say, and this data happens to show us that the poorest have less problem of overweight compared to the wealthy. I think this is obvious, you all should know. Looking at non-communicable diseases risks, we have quite old data going back to 2012, but it serves to show us that we have a major problem in terms of risks. If you look at, if you look at smoking and drinking, which is a major problem among men, but we have, sorry, yep. We have a problem of raised blood pressure among both male and female, but with obesity, it's very high among females. And since this data is quite old, one definitely would want to see what could have been the most recent. We look at governance and health financing. There you are. We have achieved in terms of governance, 90% of the CCHPs, these are the Comprehensive Council Health Plans, they are approved on first assessment. And the target was 50%. So this is over performance, I would say. However, when it comes to funding, we have gone slightly low. Sorry. We are at 8.9%, which is quite low compared to the target of 10% that we have set for ourselves. And in terms of insurance, we have 9% of adults who are covered, and this is far below the target that we have set of 50% by year 2020. In terms of human resource, I think this has been talked a lot in the morning, but here we can see the figures where we have an average or a ratio of 0.9, or you can say 1 per 10,000 population for clinicians and 4.7 for nurses, and this is quite low. The gap is still running at 50%, and you can see wide regional variation with some regions like Simi far below compared to Arusha and when it comes to number of clinicians that are there. This next graph tries to show us comparison between the density of health facilities compared to the density of health workers. And this has been plotted using the linear regression just to show you who are behaving as expected and who are behaving more or less than expected. So if you look here, you will see regions like Njombe and Mbeya and Iringa performing or having more of health workers compared to what it would be expected for the number of, or the density of facilities they have. While regions like Songwe and Lindi are having less of health workers density compared to the density of facilities that they have. And in general, with health service delivery, in terms of infrastructure, we have been told, we have been told that there has been massive investment we almost now have more than 11,000 facilities in the country, and we have almost average of 2.1 facilities per 10,000. And in terms of tracer medicine, it's 95% over the country, and star rating has been quite high. But we need to make progress on a number of things. One, workforce, but two, OPD visits. It seems that we have less than expected visits. We have a ratio of 1 visit per person. There isn't a very actual target. However, for countries like ours, we need to improve on attendance, and ratio is low. In terms of basic emergency obstetric care, we still are lagging behind. Star rating, we have been shown that almost all regions, the blue dots shows the performance in 2015, and this line shows performance 2018. So you can see a very good increase in almost all regions. However, worth noting here is that only 19% are 3 stars or more. So the achievement is mostly on increasing to 2-star. In terms of basic amenities, we had SARA, which was done 2015 and 2017, and if you compare, you will notice that we have made achievement in between the years for most of the amenities, except for emergency transport, which actually has decreased from 47% to 10%. Health information system. Health information system, now we are on the systems. It's going on quite well. We have a very good system. In fact, so to say, most of the data that we are presenting here comes from the routine health information system. Completeness and reporting rate has increased dramatically. However, there are a number of things that need to be addressed. And one is the number of data elements and indicators that are collected. They are just too many for the health workers to work with. And this calls for rationalization of what we need to collect from the field. And it also calls for integration, because most of this seems to be duplication. And unless we sit down and integrate the information systems, the number of data elements we are going to collect there is going to remain high. And integration here, let me speak on it. We are talking about integration at lowest level and not integration at higher level. Because integration at higher level may be helpful, yes, but this is the level where we have people who can read data, who can analyze data. So they may be able to do without integration, but the lowest level, they have to have the data integrated. We also faced a problem with target population. When you get down to council level and facility level, the projections of target population from NBS do not work. So we ended up using facility-based data elements as denominator to be able to come up with a good story. In conclusion, there are many positive developments with many programs coverage having increased that are mentioned. And we could see that for most of the indicators, almost all the regions performed well, although for some indicators there were wide variation between regions. We are not in track in terms of drinking water sources and sanitary facilities. We are far from target. And NCDs are coming up. They need to be looked at very closely. And the inequalities between the poorest and the richest, inequalities between regions. Neonatal and child mortality. We need to do something more to increase the speed so that we achieve our targets, and especially in urban poor, where actually there seems to be a greater need. Adolescent childbearing has been mentioned to be, quite a major problem. We need to address that. And the issue of the unmet need, much as we are having quite a good increase in terms of acceptance of family planning, but we still have quite a huge demand which we should be able to fulfill. And last but not least, in terms of the need for continuous system tracking for the progress and performance. And this we are saying because we noted that for most of the data that we had to use for this review, it wasn't quite easy task to get it. However, if this exercise was being done annually by all the programs to look at their performance every year quantitatively, I think tasks like these ones would be quite easy and necessary for that matter. And finally, we urge that the ministry should work with the technical teams and technical personalities from the available institutions that are there that can do the work, and the supportive partners that are there to facilitate in the work. Madam Chair, thank you very much for a quite lengthy, laborious presentation that we had. We tried to simplify it by putting up only 40 slides. Thank you very much.
Thank you very much, Professor Simba and Professor Sia, for that presentation. I was looking around, nobody was dozing, so it was okay. And this is a presentation of the analytical reviews. It gives the basis, the information, statistical basis from what we are reviewing. So as you ended, it's better to do continuous performance evaluation and review. And I've done that for our work today, and I've seen the need to postpone the discussion until the MTR presentation, because some of the questions will be intermingled. So please jot down your questions, and I want to invite Jap Kut and his team to present the MTR main, because they go around the same. This is giving our analytical, the data part, this is the whole. So Jap Kut, would you like to start, or I've caught you by surprise? While Jap is preparing himself and his team, I want the chairs of the RMO and the chair of DMOs to give their presentations to the Secretariat. We want the presentations now. So please hand over your presentation to the Secretariat now, and let someone let me know that you have already done so. and RRH as well. So all the presentation from the RMO chair, DMO chair, and okay, so hakuna DMO. Okay, sorry. There's no presentation from the DMOs, but the RMO and the MOH are medical officer in charges for RRH, Regional Referral Hospitals. You have also your presentation. Please hand over and someone let me know you have already received it. So how are you organizing yourself? You want the chairs there or you will stand? You stand, okay. Okay, you can stand behind your team leader so that we see you properly. So this is going to be a marathon presentation. It will be presented by 10 people, but each one going slow. Okay, Yap, it's your floor.
Good afternoon, Madam Chair, Honorable PS, Ministry of Health, Community Development, Children, Elderly, and Gender, other members of the High Table. Thank you very much for this opportunity to present. We are presenting this as a team. So you see here many people standing next to me. Introducing them, Professor Manongi, who's sitting there, Dr. Nyamtema. He's not here. Okay. Then Mrs. Adija Kweka is sitting there. Dr. Eli Nangawe is sitting here. Dr. Berege is here. Professor Munishi is here. Dr. Molel, where is he? Okay, he is supposed to be here. Wema Kamazoro is there. And Daudi Nasip is also here. So we are here presenting, and you see that this is an old Tanzanian team, and also in the analytical team were all Tanzanians. There were just 2 Dutch. Lakini wote wawili ni wameishi hapa Tanzania muda mrefu, kwa hiyo tunadai kama sisi ni wenyeji vile vile. Kwa hiyo hii ni midterm review ya kwanza ya wenyeji kabisa. So to start with some of the important issues, we are going to have a very short introduction, and then all the thematic consultants will present their findings, and finally we will come to conclusions and recommendations. The activities in the midterm review have already been shown. What I would like to show here is that we are using a mixed method of quantitative and qualitative data, and we visited 8 regions in 8 different zones, and in each region 3 different councils, and in each council 3 different health facilities, so to get a maximum mix of facilities. If you look statistically, we can say that we reach a confidence interval of 95% with an error margin of 10%, which is good enough for having an overview of the health sector that is reliable. For qualitative data that we collected, we see that we reached a saturation point, so we came up with the most important issues that are important for further analysis and further discussion. Only limitation is that for the key informant interviews, we could not reach all the people that we would have loved to interview. So the activities have been discussed by Dr. Catherine. It's important to mention that we were able to perform all activities